Acute Kidney Injury, or AKI. You are absolutely guaranteed to see this on the wards, so having a rock-solid framework for it is, well, it's not negotiable. In this quick explainer, we're going to build that exact framework step by step. So let's get right into it.
So here's our game plan. We're going to start with the basics, what AKI actually is. Then we'll build out the most important framework, the 3 fundamental types. Once we have that down, we'll jump into how you actually diagnose it at the bedside, and finally, what you need to do when things get critical.
All right, Section 1. What is acute kidney injury? Let's make sure we've got the fundamentals locked in.
Okay, so at its core, AKI is just a rapid drop in kidney function. We're talking hours to days. And when that happens, waste products like urea and creatinine start to build up, and the body's whole balance of fluids and electrolytes gets thrown way out of whack. Now you'll notice we call it injury, not failure. And that's actually really key, because it reminds us that AKI is a whole spectrum. It can be anything from a little bit of dysfunction all the way to a complete shutdown.
So to make the diagnosis official, we use what are called the KDIGO criteria. And the single most important thing to remember here is that you only need one of these to be true. It doesn't matter if it's a specific jump in creatinine or a sudden drop in urine output. Any one of these 3 means your patient officially has AKI.
And this isn't some rare thing you only read about in textbooks. AKI affects about 1 in every 5 hospitalized adults. Think about that. That means on any given day, on pretty much any ward you're on, you will be managing this. It is a fundamental part of inpatient medicine.
Okay, let's get to the most important part, the central framework for thinking about AKI. Every single case, and I mean every single one, can be broken down into one of 3 types based on where the problem is. Getting this right is the absolute key to everything that follows. So, the 3 types are prerenal, intrinsic, and postrenal. The names basically tell you everything you need to know. Prerenal is an issue with blood flow to the kidney. Intrinsic is damage within the kidney itself, and postrenal is a blockage somewhere after the kidney. Your first job always is to figure out which of these 3 buckets your patient falls into.
Prerenal AKI is by far the most common type you're going to see, making up about 70% of all cases. It's purely a perfusion problem. Not enough blood is getting to the kidneys. This could be from straightforward volume loss, like in a hemorrhage, or what we call effective hypovolemia, like in septic shock. And it's so important to remember that common drugs like NSAIDs and ACE inhibitors can mess with the kidney's ability to protect itself from low blood flow. Next up is intrinsic AKI. This is where the kidney tissue itself is actually damaged. The most common cause here is something called acute tubular necrosis, or ATN. This basically happens when the kidney is either starved of oxygen for too long, like if a prerenal state goes on, or if it's exposed to a direct toxin. You can also get other intrinsic causes that involve the glomeruli, the interstitium, or even the blood vessels inside the kidney.
And finally, we have postrenal AKI. Think of this one as a simple plumbing problem. There's a blockage somewhere from the ureters on down. Common culprits: an enlarged prostate in men, kidney stones, or even just a blocked urinary catheter. The key is that the backup of pressure is what ends up damaging the kidneys. So we have the framework, but how do we actually use it at the bedside to figure out which type of AKI we're really dealing with? Let's get into the diagnosis. Your investigation always starts with the basics: a good history and physical exam. You're going to ask about things like fluid loss, any new medications, urinary symptoms, and then on your exam, your absolute top priority is assessing their volume status. Are they dehydrated or are they overloaded? A palpable bladder is a massive clue for a postrenal cause, while something like a rash might point you toward an intrinsic cause like acute interstitial nephritis, or AIN.
Now this table right here is classic high-yield stuff for exams. But more importantly, it makes perfect sense when you think about the pathophysiology. See, in prerenal AKI, the kidney is totally healthy, it's just not getting enough blood. So it does its job perfectly. It desperately holds on to every last bit of sodium and water. That gives you very low urine sodium and super concentrated urine. But in ATN, the tubules are damaged. They can't do their job, so they leak sodium and they can't concentrate the urine at all.
And this is where it gets really cool: the power of a simple urinalysis. Looking at the urine sediment under a microscope can literally give you the answer. Those granular, muddy brown casts, that's pathognomonic for ATN. They are literally made of dead kidney cells. In the same way, red blood cell casts point you straight to glomerulonephritis, and white blood cell casts strongly suggest the inflammation of AIN.
Okay, one last essential test. For almost any patient with a new AKI, you need to get a renal ultrasound. Why? Because it's the fastest and easiest way to look for hydronephrosis. That's the key sign of a post-renal blockage. And you have to look for it because it's the most easily reversible cause of AKI.
All right, section 4, management. So we figured out the type of AKI. What are our immediate priorities? Well, there are a few key steps that apply to every single patient, no matter what.
These are your first 3 actions every single time. 1. Stop any drugs that could be hurting the kidneys. You have to review that med chart for nephrotoxins. 2. Optimize our fluids and blood pressure to make sure the kidneys are getting enough blood. And 3. Treat whatever started this whole thing, whether that means giving antibiotics for sepsis or putting in a catheter for an obstruction.
Now, sometimes AKI can lead to immediate, life-threatening emergencies. This is where you really need to act fast and know exactly when to call for help, whether that's from a specialist or the ICU.
So let's make this real. You get a call from the nurse. Your patient with AKI has a potassium of 6.8 and their ECG is showing peak T waves. This is a true medical emergency. What is your very first move?
Your response has to follow 3 steps, in order. First, and I cannot stress this enough, you stabilize the cardiac membrane with IV calcium gluconate. This doesn't actually lower the potassium, but it protects the heart from a fatal arrhythmia. Step 2, you shift the potassium out of the blood and back into the cells using insulin and dextrose. And then, for step 3, you start working on actually getting the potassium out of the body, using diuretics, binders, or, ultimately, dialysis.
So when does a patient actually need to go on dialysis, or what we call renal replacement therapy? For that, we use the classic AIOU mnemonic. This stands for severe acidosis, dangerous electrolyte imbalances like that hyperkalemia we just saw, certain intoxications, fluid overload that isn't responding to diuretics, and symptomatic uremia. If your patient has any of these, it is time to call for dialysis. So, let's end with the single most important takeaway from all of this. If you remember nothing else, remember this. The moment you diagnose AKI, your very first thought must be, is this prerenal, intrinsic, or postrenal? That one question is the key that unlocks your entire workup and management plan. Master that framework, and you will know how to approach any patient with acute kidney injury.